during Loving Care's mandatory training on fall prevention. This training is required for all employees. There are multiple handouts required for this training. Please make sure you have them prior to beginning the training. To successfully complete this training, you must view the entire video and successfully complete the post-test. One-third of people 65 and older fall each year. Less than half of the Medicare beneficiaries who fell in the previous year reported it to their healthcare provider. Every 29 minutes, an older adult dies from a fall. 1 out of 5 falls causes a serious injury such as head trauma or fracture. Over 2 million older adults are treated in emergency departments for non-fatal fall injuries each year, costing over $28 billion annually. The reason for this training is so that you will know how you can help prevent falls and how you can help in the event that a fall does occur. QAPI is a way of assessing quality and improving performance at Loving Care. Regulations require that we monitor quality and improve our performance. Therefore, QAPI is the law, but it is also a good thing to do. There are 2 different but interrelated parts of QAPI: quality assessment and performance improvement. Loving Care has 2 teams, one for home health and one for hospice. These teams collect data about the care that you provide. This is called quality assessment, or QA. The data is discussed at QAPI meetings. From that discussion, we create a problem list. Then we prioritize the problems and we figure out how to fix them. This is called PI, or performance improvement. But did you know that QAPI is not just the responsibility of the QAPI team? It's the responsibility of every employee. If you look in the employee handbook, you can read about the organization's expectations in regard to quality. It is the policy of the Loving Care Hospice Incorporated to provide our customers with services which comply with regulatory requirements and exceed patient expectations. Accordingly, we are all committed to this policy. Our insistence on quality is a way of life in our company, which invests resources in the constant improvement of the quality of the services that we provide. In light of the above, we set ourselves on the following objectives: constant improvement of patient outcomes, a pursuit of red carpet customer service and noteworthy patient and family satisfaction, improvement in efficiency by Loving Care team members, establishing and maintaining an active community presence, establishing and maintaining effective partner relationships with various community resources. All employees are accountable and responsible for the quality of care and services within their respective departments and are expected to participate in Loving Care's QAPI program. Employees are expected to cooperate with data collection strategies and to actively participate in performance improvement projects designed by the QAPI team. Employees are encouraged to volunteer for QAPI teams and suggest performance improvement projects. All employees are encouraged to volunteer in a minimum of 1 community activity to give back and to show Loving Care support for the communities in its service area. So what does QAPI have to do with fall prevention, you may be asking? The Infection Control and Safety Committee and both QAPI teams have determined that falls are a major risk for our patients. We have a high number of patients who fall every quarter, and many times injuries occur. We also see that frequently patients will fall more than 1 time. So we asked ourselves, what can we do to stop falls and to prevent or minimize injuries once a fall occurs? This is where QAPI comes in. We assessed that we had a high number of falls for our patients, which is QA, so we got approval from the Board of Directors to implement a Performance Improvement Plan, or PIP, in an attempt to reduce the number and severity of the falls that occur. This is PI. So why are you here listening to this training? Well, we just read an excerpt from the Employee Handbook about how all employees are expected to participate in performance improvement plans put into place as part of Loving Care's QAPI program. Every one of you will play a role in one way or another. First, I want to take a minute to give a shout out to a few people. When the board approved the fall prevention plan, a fall prevention team was developed in order to create the plan. The members of the team are Denise Tennell, Jason Lambert, Kelly Hughes, Melissa Fox, Mary Dangler, Sarah Queen, and myself. Thanks to all of you for all of the effort that went into this plan. Not only have they put in several hours on meetings and preparing the different aspects of this plan, but they are committing to the ongoing success of this project. As part of the project, the team designated a fall coordinator who is responsible for the oversight of the project. That person is me. I am Barbara Dixon, and I'm the Chief Clinical Coordinator. As with any project, in order to know where you're going, and if you've achieved the purpose that you set out to accomplish, we need to set a goal. For purposes of QAPI, we call this an aim statement. The aim statement for this project is, by June of 2018, Loving Care Home Health and Hospice will decrease the number of patient falls by at least 25%. We then looked at the problem and came up with 6 things that would be essential to a successful fall prevention plan. The first element is the definition of the term fall. In order to be successful with the project, we all need to be on the same page in regard to what a fall actually is. For the purposes of this project, a fall is defined as an unintentional change in position resulting in coming to rest on the ground or at a lower level. The second thing that we felt would be important in the fall prevention program is a risk assessment. A fall risk assessment should be completed on all patients at minimum at the following time points: on admission or resumption of care, at recertification, at discharge, and within 24 hours of being notified of a fall. Some of you may not be involved with a risk assessment, AIDS for example. However, it is important that ongoing attention is given to this issue. If you notice any of these risk factors, make sure to report that to the patient's nurse. Early identification of risk factors could prevent a fall. The risk factors I mentioned include high-risk medication, unsteady gait or balance issues, fear of falling or lack of confidence, orthostatic blood pressure changes, environmental issues, mental status changes, and there are many more. Those of you who are responsible for risk assessments, such as nurses and therapists, will be assessing for the risk factors that we just discussed by using these tools. The MOC-10. This is included in our EMR. Simply follow the guidance in the document for the correct scoring. A TUG. This is to be performed by RNs on patients who are ambulatory. Patients need to wear their regular footwear and use their regular assistive device. The patient then sits in an armchair. You will measure out a line 10 feet away on the floor, and if you don't already have one, we have yellow ropes that measure out 10 feet, so you don't have to measure it yourself. Get out your phone or your stopwatch. You will have the patient get up from the chair, walk to the line, turn, return to the chair, and sit down. You will start the stopwatch when you say go, and stop when the patient is seated again. If the time is greater than 12 seconds, the patient is at risk for falling. The TINETI Balance and Gait Assessment is an assessment that is done by physical therapists. All physical therapists should know how to do the TINETI, so I'm not going to review the steps today, but I have included a handout with this packet. The ABC scale. This assesses patient confidence. When patients are afraid of falling, it puts them at high risk for falls. This is a self-assessment that can be facilitated by the RN, PT, or the social worker. I have included the scale in your handouts. Orthostatic blood pressure is another major risk factor for falling, or orthostatic hypotension is a major risk factor for falling. I have included a handout to make sure that you are performing orthostatic blood pressures correctly. All staff will also be skills checked on this technique when annual evaluations are done. And finally, medication review. You'll pull out the medication review handout that was given to you. It is important to do a thorough review of all medications that put a patient at increased risk for falls, and to work with the patient's physician or the hospice team to eliminate any medications that can be safely discontinued. The third aspect of our fall prevention plan are fall prevention precautions. Once you've determined what your patient's risk level is, it's going to be necessary to implement interventions to prevent falls. The PIP has developed a standard set of precautions for use by all clinicians. Patients will be assigned precautions based on an assessed risk. A patient could be at low risk, in which case we will do universal precautions, or at high risk, which will be universal fall precautions as well as high-risk fall precautions. Remind the patient to call for assistance if needed, to transfer, ambulate, toilet, or retrieve hard-to-reach items, and to avoid bending to pick up items. Maintain walkways from excess clutter. Provide patient and family with educational handouts provided on admission. Educate the patient to inform the nurse of any symptoms such as dizziness, lightheadedness that occur with postural change, for example, lying, sitting, or standing. Use adaptive equipment in bathrooms when necessary. Front-load visits to ensure patient safety. Notify the attending physician that a patient is at high risk for falls by discussing and initiating a plan of care which addresses medications, cognitive function, gait and balance, as well as other conditions that may contribute to patient falls. Recommending, suggesting referrals or consults to address individually assessed problems. We have an algorithm for you to know what referrals would be appropriate for what problems. Discuss the conversation in the patient's nursing or document the conversation in the patient's nursing assessment and or in the telephone progress note. And educate the patient on controlled falls and a self-assessment or how to get up after a fall. In order to simplify the process, we have created a form to consolidate all of the assessment findings and to guide you in implementing interventions and developing a plan for reducing risk. I would like to refer you to the algorithm that should be with your handouts for referrals. And there is also information about controlled falls and self-assessment in your handouts. We will be talking about self-assessment later in this training. Some patients will fall despite our best efforts. It is unlikely that we will ever be able to prevent every fall. So it is important that you know what to do in the event that a patient does fall. We have broken our after-fall actions into 4 categories that vary slightly between home health and hospice: witnessed, unwitnessed, fall in a facility, call to office, patient on the floor. After-fall actions for home health. If the fall is witnessed by a loving care staff member, you will ensure that the patient is safe. Assist the patient with a self-assessment, and you will be learning about patient self-assessment later in this presentation. You'll notify the nurse if applicable. The nurse will make a home visit to assess for pain or injury. If you are not the nurse, you will stay with the patient until the nurse arrives. The nurse will notify the physician and decide on a course of action. The nurse will complete a new fall risk assessment and implement appropriate interventions. You should return to the office and complete a variance incident report. The fall must be entered into the patient's event log in the EMR. A fall report form will be completed by the home health coordinator within 5 business days and turned into the fall coordinator along with the associated variance incident report. If you were not with the patient when they fell and the fall was recent, within the past couple of hours, you will assist the patient with a self-assessment and notify the nurse. If it has been longer than a couple of hours, call the nurse to report the fall. If you are the nurse, you will talk the patient through the self-assessment while you are preparing to go to the home. If the office is reporting the fall, they will give you the results of the self-assessment. After fall actions for home health, if the fall was in a facility such as an assisted living facility or a group home, the nurse or the therapist should speak with the facility staff and identify the cause of the fall and follow the procedures required of the facility. The nurse or therapist should notify the patient's physician and the patient's family. Follow the actions for a fall witnessed by Loving Care staff member or fall unwitnessed by Loving Care staff members, whichever is appropriate. And then attempt to obtain a copy of the facility fall report. For both home health and hospice alike, there are times when a patient may call the office because they have fallen and they are on the floor. The procedure is the same for both home health and hospice. The receptionist or on-call nurse will assist the patient with a self-assessment. During office hours, the closest nurse will make a home visit to assess and to help. After hours, the on-call nurse will make a home visit to assess and help. Once at the home, you will follow the action items for fall unwitnessed by Loving Care staff members. After fall actions for hospice vary slightly from home health. Fall witnessed by Loving Care staff member. This is the procedure you will follow if you are with a hospice patient when they fall. Ensure the patient is safe. Assist the patient with a self-assessment. Notify the nurse if applicable. The nurse will make a home visit to assess for pain and injury. If you are not the nurse, you will stay with the patient until the nurse arrives. The nurse will notify the physician and decide on a course of action, taking into consideration the wishes of the patient and family. A few suggested actions would be monitor the patient, mobile x-rays, or send to the ER. The nurse will complete a new fall risk assessment and implement appropriate interventions. Return to the office and complete a variance or incident report. Enter the fall into the patient's event log in the EMR. A fall report form will be completed by the hospice coordinator within 5 business days and turned in to the fall coordinator along with the associated variance or incident report. If you were not with the patient when they fell and the fall was recent, within the past couple of hours, you will assist the patient with a self-assessment and notify the nurse. If it has been longer than a couple hours, call the nurse to report the fall. If you are the nurse, you will talk the patient through the self-assessment while you are preparing to go to the home. If the office is reporting the fall, they will give you the results of the self-assessment. After fall actions for hospice in a facility, the facility staff will do a head-to-toe assessment. The loving care nurse will notify the patient's physician, the hospice physician, and the patient's family. Follow the items for a fall witnessed by loving care staff members or a fall unwitnessed by loving care staff members, whichever is applicable. Obtain a copy of the facility fall report. Assist the facility to identify and implement new interventions and obtain a copy. You have heard me mention patient self-assessment several times during this training. All staff need to memorize and know how to talk a patient through performing a self-assessment. Anytime that you encounter a patient who has recently fallen, whether on the telephone or in person, you will walk them through this procedure. Instruct the patient that they should not try to get up right away. Have them relax and take a few deep breaths. They should stay on the floor for 3 to 5 minutes. Do not assist the patient off the floor. Instruct the patient not to allow anyone other than their healthcare team or EMS to assist them off the floor. If the patient is unable to move at all or has heavy uncontrolled bleeding, call 911 immediately. Instruct the patient to do the following. Point and flex your foot. Move your foot in a circle. Switch feet. Point and flex your foot, and then move your foot in a circle. Slide your heels towards your bottom, and then slide them forward. Move your wrists up and down, and in a circle. Open and close your hands. Reach your hands towards the ceiling. You have a handout about how to get up off of the floor. First thing the patient is going to do is to prepare to get off the floor. They would do this by taking their time and then looking around to locate a sturdy piece of furniture or the bottom of a staircase. They should roll over onto their side by turning their head in the direction they're trying to roll, and then move their shoulders, arms, and hips, and finally their leg over. The patient should push their upper body up, lift their head, and pause for a few moments to steady themselves and see how they feel. If they still feel okay and there is no pain, they could slowly get up on their hands and knees and crawl to the sturdy chair or the staircase. They should place their hands on the seat of the chair and slide one foot forward so that it is flat on the floor, keeping the other leg bent with the knee on the floor. From this kneeling position, they should slowly rise, turn their body to sit in the chair. They should sit for a few minutes before trying to do anything else. And again, they should follow up with their physician. The fifth piece of this performance improvement plan included staff education. This is what we're doing right now, teaching everyone the plan. Everyone will be skills checked on knowledge of fall precaution, patient self-assessment, and any other skills that we have discussed during this in-service that pertain to your role. For example, PT will also be checked off on the Mach 10, Tenetti, ABC scale, controlled falls. Nursing will be checked off on Mach 10, tug, orthostatic blood pressures, medications, etc. And the final piece of the performance improvement plan is patient education. All patients will be educated about fall prevention or safety. General fall prevention strategies will be given to all patients. Patients who have been identified as high risk for falls will also be educated about self-assessment after a fall and how to minimize injuries in the event of a fall. This is the controlled falls handout that I have given you. It is important to make sure that the patient understands that there is no safe way to fall, that all falls could result in an injury, and the best prevention of injury is to prevent the fall altogether. However, should a fall occur, there are 3 important rules for the patient to remember. The first rule is to protect their head and neck. The second rule is not to put their hands out in front of them to brace themselves against impact. And then the third rule would be to relax. If you have any questions about this fall prevention plan, you can refer them to the fall coordinator, which is myself, Barbara Dixon, or to anyone on the fall prevention team. Thank you for your attention to this